So you've heard already from everybody's talks from this morning how important and prominent genetics has become for all of our fields, and I think this slide just highlights how much it's also been in the news. For years now, for about 10 to 15 years, we've been excited about the genome. We've been excited about the advances that have been coming down the pipeline pretty rapidly. And I think in cancer probably is the one area where it's really evolved the most rapidly. And this is what you're going to hopefully learn in the next 3 lectures, is that we are using this information in real-time clinical care of patients. And I think in the past year, this is Angelina Jolie's diagnosis of a BRCA mutation plus her decision to undergo prophylactic mastectomy has really, you always need a celebrity, and Angelina's as good as they come, has really brought this back to the public view, is that, how is genetics changing how we care for patients, how we think about risk, how we make management decisions. So this is breast cancer. In colon cancer, it has been a rapidly evolving field. And I think for me, doing this now for the past almost 15, 20 years, it's been fascinating how much has changed. And if I can do one thing today, hopefully one of the young people in the audience will choose to make this sort of a career focus here in Columbia. I think we really need more concerted efforts to think about genetics, to take care of these families, and to think about genetic sort of implementation in a systematic way in the care of our patients. So just some nomenclature. This talk is going to be about Lynch syndrome. And then we're going to talk about the polyposis syndromes, later on in the morning, and later in the afternoon, we're going to talk about pancreatic cancer. I've put in a few slides in the next lecture about hereditary gastric cancer as well. So lots of genetics and lots of areas where you need to think about it in your patients. So let's first think about the difference between polyposis and non-polyposis. It generates a lot of confusion, I think, and has in the past. So polyposis is just a phenotype that's characterized by forming an excess number of polyps. These are the different syndromes that we are now thinking about. So there are the adenomatous polyposis syndromes. There are the hamartomatous polyposis syndromes. There's now more and more attention on hyperplastic polyposis, serrated polyposis, mixed polyposis. So everything that I'm going to sort of talk about in classic FAP, we need to think about with these sort of more recently emerging phenotypes or descriptions. Non-polyposis, basically all it means is that you don't have a polyposis phenotype. So it doesn't mean that people don't form polyps. It just means that they don't form an excess number. And really the big sort of groups in this is Lynch syndrome. These patients do get adenomas. They get their cancers from adenomas. They just don't have 10s or 50s or hundreds of polyps. So really I want you to think less and less about the term non-polyposis and think more and more of calling it once again Lynch syndrome. And in terms of causes, what about sort of how do we think about in terms of frequency? So the first thing to know is that all these genetic syndromes are quite rare, okay? They're unusual. The vast majority of your patients are going to have sporadic forms of cancer. You don't have to think about genetic disease for the vast majority of them. In about 10 to 20% of cases, they have what's so-called familial cancer. Now this is the same thing as an IBD, celiac disease. These are people who have some genetic risk, but it's not a dramatically elevated risk. There's probably lots of interactions between different genes. There's lots of interactions between genes and environment. Those are not what we're talking about today, and these were sort of the subject, of our moderate risk group in the earlier lecture, where we're screening people more frequently than the average person, but they're very different than these very characteristic, highly penetrant syndromes that carry with them dramatically elevated risks of cancer. Here's the slide again, and really the big thing I want you to notice here, this I think we all knew, FAP has a very high rate of colon cancer, Lynch syndrome, 70 to 80% lifetime risks. What's happened over the last 15 years or so as we've done more sort of directed research in these hamartomatous polyposis syndromes is that we're realizing that they actually do have a very significant colorectal cancer risk. We used to learn years ago that that these were hamartomas. They did not have a cancer risk. That's certainly just not true. So the lifetime risk in these syndromes is about 15 to 40%. So just to orient you again, with the case of Lynch syndrome, 35-year-old with cecal carcinoma, no other polyps. Family history is notable for a mother with endometrial cancer at age 50. This should immediately make you think that there's something wrong. The patient is too young to get colon cancer, and the link to the endometrial cancer needs to be made. So what you should be thinking about is there a genetic predisposition to cancer in this case? What are the primary diagnostic considerations? Would you recommend any tumor-based testing on that colon cancer, on that cecal cancer, or think about genetic testing on a peripheral blood sample? If you're going to do genetic testing, what genes would you test for? What surgery should he have? Very important question. And then when would you recommend that he have his next colonoscopy? So clinical features of Lynch syndrome, it's a classic syndrome described by Henry Lynch as far back in the 60s. And what he told us was that there was a very early but variable age at colon cancer diagnosis. So you can certainly see patients who have cancer at 35, but you can also see people who have a mutation that don't get colon cancer till their 60s. They get multiple primary cancers. So if you have more than one colon cancer in a patient, think about Lynch syndrome. Accelerated carcinogenesis. This is a hallmark feature. So it doesn't take 10 years for a patient with one of these mutations to develop colon cancer. It's probably 3 years. It takes maybe 4 years. And one of the biggest problems is that these people get cancers rapidly. And this affects the recommendations that we give these patients. Tumor site predominates in the proximal colon. We don't really understand why. It's helpful if you find it, but certainly these people can get left-sided cancers too, so it's not that helpful. The biggest issue with the syndrome is all these sort of extra GI tumors that require you to make the links and get the family history. So uterine cancer is the most common, but they get ovarian cancers, they get other GI tract tumors, they get transitional cell tumors of the urinary tract, sebaceous skin cancers. So you may get a referral as a gastroenterologist from a savvy dermatologist who's picked up a sebaceous carcinoma to make you think about Lynch syndrome, and that's actually very appropriate. Why do we get it? In the early 1990s, we discovered that there's a whole class of genes called the mismatch repair genes. So until then, we knew about tumor suppressor genes, we knew about oncogenes, and what this discovery showed us was that there are a whole set of genes that fix mistakes that occur during DNA replication. And when they don't work, you get something called microsatellite instability. The first discovery was of MLH1 and MSH2, and since then there are a total of 5 genes that have been discovered over the years that are responsible for this syndrome. Now, the phenotypes that you need to be aware of, and I think all of us have heard these terms more and more in the last few years, but we're going to talk a lot about how you use them in your clinical practice. So when you get a defective mismatch repair gene, you get a phenomenon known as microsatellite instability. And when one of these genes is mutated, what happens is that the gene doesn't make the protein doesn't get expressed, and you can actually do immunohistochemical analysis on the tumor sample for loss of expression of the tumor. That's a very easy test to set up in any molecular diagnostics lab. It's the same IHC test, or same techniques that are used for lots of other pathology tests. So it's something that's very feasible to be done on a large-scale basis in a population. What are microsatellites? So they really are just sort of markers. It's a phenotypic marker. They're areas where you have multiple DNA repeat sequences, and these areas are just prone to mutations. So you get something called a mutator phenotype. And what is now become clear is that in about 15 to 20% of sporadic colon cancer, you have microsatellite instability. And we had talked earlier on about this whole serrated polyps and right-sided colons. It's becoming clearer that these microsatellite unstable sporadic cancers probably are part of the serrated polyp pathway and account for some of these right-sided high-risk colon cancers and adenomas that we're used to seeing. In Lynch syndrome, 85 to 90% of the tumors show evidence of microsatellite instability. So 15% of sporadic cancers, very, very high proportion of Lynch syndrome patients. You also see microsatellite instability in endometrial cancers, and you can also see microsatellite instability in adenomas for Lynch syndrome patients. So as we think about how to do testing in tumors, we can think about it in cancers, but we can also think about it in large adenomas. So I'm going to start with management because I think the biggest sort of reason to think about identifying Lynch syndrome patients is because it's going to affect how you take care of these patients. So how does management of these patients differ? The surveillance frequency of at-risk individuals is completely different than in the sporadic population. The surveillance post-treatment of their primary cancer, after if they get cancer, is very different. We're going to talk about surgical management of cancer in these patients. You need to think about surveillance for associated cancers. So, you know, we are all gastroenterologists. We think about GI cancers. But you may be the only person who is seeing a young patient with colon cancer. And if it's a woman who needs to get referred for uterine cancer screening, you may be the only person who has to think about that and make that referral. And screening and surveillance of family members. So we are used to taking care of our own patients. We're not so used to taking care of or thinking about the extended family. And all of these genetic diseases require us to think beyond our patient. So if you're going to remember anything, this is the slide to remember. The surveillance for Lynch syndrome should be by colonoscopy. So all those other tests that we talked about this morning are not relevant because the risk is so high. And because of this accelerated carcinogenesis, it needs to start early and be repeated every 1 to 2 years. And the biggest management mistake that we see in these patients is that they get interval cancers. So somebody gets a family history, they get told to come back in 5 years, and while they're waiting for their next colonoscopy, they develop an interval cancer. So you need to actually scope them, and we do it annually for the vast majority of our patients. For endometrial cancer, it's recommended that you do something for the risk. And if you look at any guideline, all the guidelines recommend transvaginal ultrasounds and endometrial biopsies, starting, and the age has been sort of increasing, probably 30 to 35. We have no data to suggest that any of these approaches in endometrial cancer actually work, but in colonoscopy, we actually do know. Thank you. So this is a study from Finland that showed us a while ago now that colonoscopy screening for at-risk individuals actually helps. So it decreases both incidence and mortality for these patients. In terms of prophylactic surgery, so we're going to talk about polyposis and talk about prophylactic surgery in that context. For the vast majority of Lynch syndrome patients, you don't need to take out their colons. You can do screening and vigilant screening. The big exception is when they get a colon cancer. And I think I wish the colorectal surgeons were in this room because that's really become one of our biggest sources of referrals for this syndrome, is the surgeon is seeing a patient, a young patient. They realize that they should be thinking about Lynch syndrome. We do the diagnostic testing pre-op, because what's recommended is that that patient needs a subtotal colectomy for their surgical operation rather than a segmental resection. And this is because these patients have such a high rate of forming subsequent cancers in the future. So really this is a very appropriate, again, reason for referral. Now, for uterine and ovarian cancer risk in these patients, you know, I told you that the screening does not work, and we really use it as a bridge to get patients to prophylactic hysterectomy and oophorectomy. So in the 40s and 50s, people are undergoing prophylactic hysterectomy and bilateral oophorectomy as a way to manage their risk, and that's really very common in these mutation carriers. Now, this is some recent data that actually shows us that it's reasonable to do subtotal colectomies in these patients. Large study, almost 400 mutation carriers. And they compared people who had extensive colectomy versus segmental resection. This is the important number here, that the risk of metachronous cancer, so a second cancer, was reduced by 31% for every 10 centimeters of colon removed. So you really need to remove surface area, basically, to get rid of risk in these patients. So it's given us a lot of justification to recommend subtotal colectomy. Now, as we're managing the colon and GYN tumors better, what's emerging is that these patients also get other types of cancer. So this is a paper of ours from JAMA from a few years ago that showed a dramatically elevated risk of pancreatic cancer in mutation carriers. And as you can imagine, pancreatic cancer is much harder to manage in terms of risk than some of these other cancers. And this is a recent study that looked at a large number of mutation carriers, followed them prospectively to see what kinds of cancers they would get. And I'll point out here again, so this confirms this pancreatic cancer finding, but these patients have, 10-fold increased risks of gastric cancer, 10-fold risks of urinary tract tumors, maybe even an elevated risk in prostate cancer, maybe an elevated risk in breast cancer. So it's going to get more and more complicated how to manage these patients as we go about in the future. And finally, in terms of management, aspirin and Lynch syndrome, there was a large European study that looked at aspirin chemoprevention for these mutation carriers. And in the first report of this, it was a negative study, a New England Journal article that showed no benefit of 600 milligrams of aspirin in patients with Lynch syndrome. And what happened is that the investigators followed these patients for a longer period of time, and 4 years later, they actually could show a beneficial effect at reducing cancer. So their cancer risk reduction was almost 60%. They showed a reduction in endometrial cancer. There was no prevention of adenomatous polyps. So this study has raised the possibility of chemoprevention in these patients. The big problem has been the dose. So it's really 600 milligrams of aspirin is a lot of aspirin to take, and you need to take it for many years. So you really didn't see a beneficial effect if you didn't take it for more than 2 years, and you needed to wait for almost 10 years to see an impact. So it's something that's coming down the road, and you should think about for your patients, but we're not routinely using it. So our approach to Lynch syndrome mutation carriers is that we do colonoscopic surveillance every year. We do subtotal colectomy if colon cancer develops. We use transvaginal ultrasounds and endometrial biopsy starting at age 35. We strongly encourage hysterectomy and oophorectomy in the perimenopausal years. And we do annual skin exams and upper endoscopies for the gastric cancer risk. Some of these on a case-by-case basis we do consider. So if you have a pancreatic cancer in the family, we think about surveillance. We're going to talk a lot more about that in the afternoon. And we think about some of these other approaches, again, if there are those cancers in the family. So next, I just want to talk about how do we find these patients, because that's really been the biggest problem is that, all of you, if you're not seeing Lynch syndrome regularly in your practice, it's because you're missing it. We're seeing a lot of patients who are at risk for colon cancer. The incidence rates are about the same as hereditary breast cancer, and really it's about how do we sort of find these patients based on family history or tumor testing. This is a landmark study that was published last year from a Spanish group that looked at universal testing with immunohistochemistry of 10,000 cancer patients in Spain, and basically showed that if you did IHC on colon cancer tumors, you could pick up Lynch syndrome in 100% of cases, much better than any of these clinical criteria. So this has actually raised a lot of question about universal tumor testing in the literature. So at least in the US, we are talking about looking at all colon cancers pathologically for immunohistochemistry or microsatellite instability. And I'll be curious in the question and answer period to sort of talk about this, about what the thinking is here in Colombia. In the US, about 90% of comprehensive cancer centers are doing this universally for colon cancer, and it's starting to catch on for endometrial cancer as well. The other option, if this is not feasible, and it's probably not feasible for, for much of the world, is to really focus on personal and family history criteria. And just so you know what these are the classic guidelines. So the Amsterdam guidelines said that you need 3 relatives with colon cancer in the family. 2 should be recognized, they should be in 2 generations, and 1 cancer should occur earlier than age 50. And what we know is that some of these guidelines are just not sensitive enough. So if you rely only on them, you're going to miss a lot of these patients. So the world has sort of moved on to prediction models that are available sort of in the literature and on the web. And I'm going to talk to you about PREM, which is something that we've developed. Faye Castrinos from Columbia was the first author of the second paper. And basically, if you go to the Dana-Farber website, I've put the link on here, it will guide you through your patient's history and their family history, and will give you a predicted probability of carrying a mutation in one of these genes. And just to show you how it works, so this is, there are 3 fields like this. It takes less than a minute to fill out, and it will say how many separate colon cancers has your patient had. You answer the questions, and it will give you a number of the likelihood of mutations. And I think around the world, this has really become sort of a risk assessment tool that's widely used in the clinic for risk assessment of these patients. So you have 2 options. You can run these models, or you can think about universal testing of the tumors, and again, we can think about how to do this. So finally, what to do if genetic testing is not available. So I understand in Colombia it's still very difficult to get testing. You have to remember that these patients have a 80% lifetime risk of colon cancer, and these women have an endometrial cancer risk. So if you decide not to do any molecular testing whatsoever, you should still think about managing these at-risk patients in the ways that we've discussed, which means close surveillance, annual colonoscopy, subtotal colectomy, consideration of prophylactic surgery, and consideration of aspirin in your at-risk patients. Thank you very much.